Good morning, everybody. It's actually almost afternoon. My name is Larry Alfheimer, and I am the chairman of the Macular Degeneration Association. This is part of a series of educational conferences that we invite interested persons with various eye conditions, which is the special focus on macular degeneration, of course. These programs are sponsored with educational grants from Regeneron Pharmaceutical, Novartis Pharmaceuticals, and Nodal Vision. You'll hear more about those later. I'd like to introduce now the subject is eye emergencies, and the speaker is Yasmin Malley, who is the beautiful wife of our chairman, of our medical director, Joshua Malley. And I hope he's watching as well, the presentation. Dr. Malley, this is Dr. Yasmin Malley, is a pediatric ophthalmologist and strabismus specialist. She graduated summa cum laude from Rutgers University School of Arts and Sciences and earned her medical degree from the Robert Wood Johnson Medical School in New Jersey. She completed her internship and ophthalmology residency at Albany Medical Center in Albany, New York, where she was awarded Knight of the Blind by the Lions Eye Institute and an honorary Saratoga Springs Lion. Dr. Malley completed pediatric ophthalmology fellowship at Duke University Eye Center in Durham, North Carolina. She was also a clinical associate. It's now my pleasure to introduce Dr. Yasmin Malley. Dr. Malley.
Welcome to this presentation on eye emergencies. Today, we're going to be talking about some eye emergencies. Obviously, there are many different types of eye emergencies, but I have selected the more common things that we see to talk about today. First, we'll begin with a few names and structures of the eye. And as you can see, this is an external photograph of the eye and the front part of the eye where we see the white, we call that the sclera, and the sclera has a clear covering called the conjunctiva. Where we see the colored part of the eye, the colored material is called the iris. In front of the iris is a clear window. That clear window is hard to see in a photograph, but I'll show you a cross section of the eye where you can see that the clear window called the cornea is in front of the colored part of the eye, the iris. And the pupil is in the center where there is actually no iris, and that's how the light gets through to the back of the eye. And here is the cross-sectional photograph of the eye, just to show you there are a lot of structures in and around the eye, and it's a very complex organ. And there are a lot of different things that can go on in the front or the back of the eye. And here we have the skin, the eyelid skin. We have muscles that are connected to the skin. We have muscles that are connected to the eye itself. We have this clear window called the cornea. We have this space between the cornea and the rest, the colored part of the eye and the lens. Often you'll hear that term anterior chamber. If you hear your doctor talking about anterior chamber, they're talking about that front part of the eye, that space between the clear window, the cornea, and the colored part of the eye, the iris and the lens. The back part of the eye we call the posterior part of the eye, where the retina lines the back wall. And here we have the optic nerve, which transmits all the information to the brain, all the visual information. So again, here just emphasizing the back part of the eye, everything behind the lens, the wallpaper on the back of the eye, as you know, we call the retina, and the optic nerve that transmits not only the visual information, but also the vessels, the artery and the vein that supply blood to and from the eye travel through the optic nerve as well. So here is a photograph of what we call the fundus, the back part of the eye. So if you were to look inside of the eye at the back wall, you would see the optic nerve. You would see the blood vessels emanating from the optic nerve. And you would see the area here, what we call the macula, which is where you have your best vision. And the center part of that macula, what we call the fovea. So the most important things here are the optic nerve, the structure that submits the information, the visual information, and the vasculature, the blood vessels to and from the eye, and then the central part of the retina, what we call the macula, where you have your straight on central vision, your best vision there. Obviously, your peripheral vision comes from everything else in your retina on the side. So we're going to start off with a condition called central retinal artery occlusion. It's something that you may hear called an eye stroke. It's very similar to a stroke that you'd have, in your brain, except it's happening inside of your eye itself. For example, you often see this in somebody, maybe 70 years old or 80 years old with complaining of a sudden, profound vision loss in one eye. It's very profound. It's described, that it happened all of a sudden, and there's no pain associated with this condition. So if you were to look at this patient externally, the eye would look like it always does. There wouldn't be any obvious changes noted out externally. But if you take a look inside of the eye, you can see that the center part, the macula, has what we call a cherry red spot. And there's whitening around the cherry red spot around the rest of the retina, which shows us that there's swelling, what we call edema of the retina. And this is a classic finding in central retinal artery occlusion, which basically means that one of the arteries in the retina has a plaque or a clot that's blocking blood flow from reaching the retina. And there are various arteries. There's the central retinal artery, and then there's branches of this central retinal artery. So the plaque can be in the central retinal artery itself, right, which comes through the optic nerve, or it could be in one of the branches. And depending on the location, the visual prognosis is determined. If the plaque is in the central retinal artery itself, then the vision loss is typically irreversible, unfortunately, and a complete, vision loss. I would like to, just tell you a little bit more about it. The important thing to know, if you are diagnosed with this sort of eye stroke, what we call a central retinal artery occlusion, it's to follow up with your doctor, because you must treat the underlying medical disease, and conditions that are associated with central retinal artery occlusions include high blood pressure, hypertension, diabetes, high cholesterol, heart disease. And so these conditions are risk factors for a central retinal artery occlusion. So it's important to have these conditions evaluated and make sure that they're properly managed and treated, hopefully before this occurs. But if this occurs, you want to identify where this plaque came from, and how to prevent this from happening in the other eye or in the brain. So I wanted to mention another type of sort of eye stroke that is not necessarily an emergency in the true sense of the word emergency, but it's one that happens in the vein. So the artery, if there's a plaque or a clot in the artery, that can lead to the occlusion, the central retinal artery occlusion. However, sometimes conditions like high blood pressure, heart disease, high cholesterol, diabetes can lead to a stiffening of the walls of the artery itself. And when the walls of the artery get hard and stiff, it presses down on the vein. And so the vein is not able to transmit the blood back to the heart. And when that happens and the vein is occluded because of pressure from the hard artery, the vein can become occluded. It can lead to what we call a central retinal vein occlusion. So I'll show you a picture of that. This one, as you can see, presents completely differently as far as the exam in the retina. You have what we call a blood and thunder appearance, where there's blood spots, what we call hemorrhages, all over the back part of the eye. It is, quite dramatic when you look at this photograph, and when you look inside a patient's eye that has this condition, it's very obvious that, this is the condition that they have when you see this blood and thunder appearance. So again, the risk factors include high blood pressure, atherosclerosis. So it's important to follow up with your medical provider and pay close attention to your blood pressure. And, if you are diagnosed with a central retinal vein occlusion, the vision loss is not sudden and profound like the artery occlusion. The vision loss is a more subacute process, sort of happening, maybe over a 24 to 48 hour time period, not a dramatic all of a sudden loss. And it's very important to follow up with your ophthalmologist if you have a vein occlusion, because there's a number of sequelae that can occur and affect other parts of the eye if this condition is not treated by your ophthalmologist, including high intraocular pressure and other blood vessel formation, which can lead to further vision loss. So important to follow up with your ophthalmologist if you're diagnosed with the vein occlusion. And here's just another picture of the, diffuse hemorrhages, blood spots all over the retina. Again, it presents as a subacute vision loss as compared to the profound sudden vision loss of an artery occlusion. And it's important to make sure that you check blood pressure and follow up with your medical doctor for evaluating any of the risk factors, as we mentioned before. So we're going to move on to something a little bit different, vision loss associated with headache. Now, there are quite a number of things that can present with vision loss and headache, but one in particular that I'd like to focus on today is called giant cell arteritis or temporal arteritis. The term that we use, the medical term, is ischemic optic neuropathy in order to describe exactly what's happening to the eye. So you see in this picture, the optic nerve, there is a blood spot of flame-shaped hemorrhage here. There's swelling of the border of the optic nerve. And these signs, in conjunction with the symptoms that the patient is describing, lead us to, suspect giant cell arteritis, and often occurs in patients over the age of 50 with vision loss, swelling of their optic nerve, weight loss, and headache. The headache is in the temporal area, so right on the side. Often patients describe it on one side or the other. There's scalp tenderness with hair brushing, ear discomfort, pain with chewing. That's often described in patients with this condition, episodes of transient double vision or vision loss, general fatigue, malaise, anorexia, and oftentimes you'll hear aching of the larger muscle groups, or even the patient is already diagnosed with a condition called polymyalgia rheumatica. So that can be associated with giant cell arteritis or temporal arteritis. Those names are interchangeable. So if you suspect this condition, it's important to get evaluated right away. You go to the ER and they would draw your blood, and they'd also consult an ophthalmologist immediately if you were in the hospital or the ER, and oftentimes begin steroid treatment to preserve vision in the other eye, because this condition can progress and affect both eyes if not treated, soon as possible. And the biopsy of the temporal artery is done to, verify the diagnosis of giant cell arteritis. And even before they, do the biopsy, they start you on the steroid treatment so that, to prevent vision loss in the other eye if this condition is suspected. Now, I'd like to move on to what we call red eyes. So the conditions we talked about already, looking at the eye from the outside externally, you couldn't really tell that there's something going on necessarily. But oftentimes the patient's eye is red or your eye is red, and those can be emergencies too. So wanted to talk a little bit about red eyes. And here we have a picture of, you know, blood layering down in that front part of the eye, and that space between the cornea and the colored part of the eye, the anterior chamber is what is referred to. And this layering of blood, called hyphema, often occurs with trauma to the eye. For example, somebody who was punched in the eye with a fist, or you know, with a ball, or, you know, some sort of blunt or other trauma. And there are certain, you know, risk factors that can lead to increased, you know, blood pooling in the front part of the eye. The vision is decreased, there's pain, there's light sensitivity, and, you know, with trauma, there's bruising and swelling of the eyelids. And the cornea, that window, is hazy. Normally that window should be clear so you can see best and clearly out of it. But if that window, that cornea, gets cloudy or hazy, sometimes it can get so cloudy that it obscures our view into the back of the eye to evaluate the retina. And it's important, when you have somebody with blood in their eye, to evaluate in the front part of the eye, to evaluate the back of the eye, to get a view of the retina, and to really get a view of the whole eye. Because this, you know, sort of hyphema can be a sign of, you know, a tear of the eyeball itself, an opening of the eyeball, what we call a ruptured globe. And I'll show pictures of that a little bit later. But when you have a hyphema, when it's just blood, if you see blood, you want an ophthalmologist to take a look at this, to make sure it's not anything more extensive, to check the eye pressure, to make sure that eye pressure doesn't need to be treated, and to begin the drops necessary to help clear the blood out of the front part of the eye. And again, with any sort of trauma, you want to evaluate the back of the eye, as well as the structure, the wall of the eye, to make sure there aren't any cuts. If there are any cuts or lacerations at any part of the eye, the wall of the eye itself, the sclera, the front part of the eye, there any opening, we call that a ruptured globe or an open globe. This is a serious emergency, needs to be taken care of immediately, because obviously the integrity of the eye is compromised, the fluid inside of the eye is leaking, and it's necessary to identify where the opening is and to close it in the operating room. So sometimes you can't see it. You can't see the opening, the laceration, just looking at the eye. Sometimes the laceration's like towards the back, or obscured from all this swelling and blood that has accumulated around the eye. And when you see all of this blood and also swelling, we call it 360 degrees of chemosis and hemorrhage. And that is something that would make us very concerned about a possible open globe or ruptured globe. And I'll show you, and so I'll show you a contrasting picture here, where you can see this patient has a laceration of the cornea, and there's iris material, you know, leaking out of their eye through that cut of the cornea, and the rest of the eye looks, you know, not too bad, not too, you know, red and swollen like the, you know, this picture here. But this is also a ruptured globe, open globe. It's just the location of the laceration is different, and so it can present, you know, in various dramatic ways. But this also would need to be surgically addressed immediately to preserve as much of the eye and vision as possible. Here's some other pictures. Here you can see again the iris. Sometimes we call that uveal material. This is not supposed to be outside of the eye. This is supposed to be inside of the eye. And so it can present in all different ways. But if you see any sort of blood or iris material out of the eye, you need to see an ophthalmologist. Go to your closest emergency room, and they will make sure this is taken care of immediately. I'd like to transition to chemical injuries. And here's some pictures. You know, if you ever get something splashed into your eye, acidic material or alkaline material, you can see that there's, again, you know, redness and swelling of the cornea, where the cornea becomes cloudy. It's going to affect your vision. The most important thing here is to irrigate as soon as possible, irrigate the eye immediately to, give you the best chance of recovery. And again, you want to see your ophthalmologist as soon as possible. And here's this was just a summary kind of going over the things we just discussed, but I'm going to move on to the next slide. And here's a picture, just to talk a little bit about angle closure glaucoma. I know a lot of patients have open angle glaucoma, but that's something that's managed, it's chronic, it's followed. Angle closure glaucoma typically, kind of presents on a more acute basis. It does need chronic follow-up, but the presentation is a little bit different. The eye, is red. The pupil is what we call fixed, that meaning when you shine a light in it, it's not really opening and closing very well. The pressure in the eye would be quite high. It's often associated with nausea, vomiting, headache, and this also needs treatment right away. So you definitely need to see your ophthalmologist to give you the medications necessary to lower the eye pressure, either drops and or intravenous medications sometimes, depending on the how high the pressure is in the eye. This picture just shows, again, just to emphasize, angle closure glaucoma. The angle, we call the angle, is talking about the cornea and the color part of the eye, the iris. That angle, if that space is not very open, if it's narrow, or even if the iris and the cornea are touching, that's what we call angle closure glaucoma, right? That space is this sort of flattened, and there's no space there for fluid, for what the aqueous fluid to move around, and that's what is exemplified here with these two lines. When we're looking at your eye through the slit lamp, we can shine two beams of light, and when these two beams of light are touching as they are here, that's suspect for angle closure glaucoma. Here we have viral conjunctivitis, and just to compare and contrast that to bacterial conjunctivitis, with viral, you have more of a watery discharge. It's highly contagious. You often see some palpable lymph nodes in and around the ear and the neck. It's associated usually with an upper respiratory infection, fever, sore throat. Bacterial conjunctivitis, you have a more purulent discharge, and it would need antibiotics for treatment. As far as anterior uveitis, is a condition where there's inflammation inside the eye, in the front part of the eye, can cause the eye to be very uncomfortable and sensitive to light, very painful, red, and the condition is treated depending on the etiology of the anterior uveitis. Sometimes the etiology is not identifiable, but there's drops and systemic medications that can help with anterior uveitis. As far as the front part of the eye, I wanted to talk a little bit about the cornea, just because some of these things we see quite often, and some of them are emergencies and some of them are not. For example, when you have an ulcer in the front part of the eye, a corneal ulcer, you can see that there's this cornea. You can just say it's mucked up, right? It's not clear, it's hazy, it's irregular. There's a layering of this white material at the bottom. That's what we call a hypopeon, when inflammatory cells layer at the bottom. This is a corneal ulcer. That's an eye emergency, needs to be treated, seen by an ophthalmologist immediately. On the other side, we also have corneal abrasion, where the front layer of the cornea, the very top layer, has been just disrupted, and you can see that here. There's a defect on the top layer of the cornea, and you can consider that like a scratch on the front part of the eye, and that can be very painful and should be treated with antibiotic ointment and drops. But sometimes we see patients and they have a very painful eye, and they have dry eye, and dry eye can be very painful, but it's not an emergency. It's something that can be seen in the office in a follow-up. And this just to put a little humor into the presentation. We've got these two men in the desert, and this guy with dry eyes and using the last bit of water available to lubricate his eye. And dry eye is can be very painful, but there are a lot of treatments for dry eye, which I'm sure your eye doctor can tell you all about. But again, it's not an eye emergency in the true sense of the word emergency. So moving on, wanted to just show you about foreign bodies in and on the eye. Sometimes they can be on the cornea itself. They could be underneath the eyelid. So it's important to flip the eyelid to make sure there's no foreign object causing a scratch, causing an abrasion on the cornea. Again, sometimes this sort of object can be inside of the eye. If there's an open globe, we always check and make sure there's no foreign material inside of the eye itself that would be necessary to remove surgically. And we talked a little bit about this layering of white material, what we call a hypopeon. It's basically inflammatory cells that are released into the anterior chamber when there's an infection, or sometimes even just a pure inflammatory process, and they kind of layers at the bottom. This can be seen in a condition called endophthalmitis. Endophthalmitis is an infection of the entire eye itself, involving the back part of the eye, the retina, the jelly in the back part of the eye in front of the retina. We call that the vitreous. And it can present with this hypopeon, with this layering of inflammatory material at the front part of the eye. And this is a true eye emergency. It would need to be seen by your ophthalmologist immediately. And just to compare and contrast that to the corneal ulcer means the infection is solely in the front part of the eye, on the cornea, the window, of the eye, and not involving the back part of the eye. If this infection were to spread to the back of the eye, we would call that an endophthalmitis. But as long as it's in the front of the eye, it's considered a corneal ulcer with the hypopeon, the inflammatory material layering. Again, another emergency, needs to be treated by your ophthalmologist immediately to preserve any vision function of the eye. Moving on to the back part of the eye, a little bit, the retina. If you have a tear or a detachment of the retina, you may notice flashing lights, floaters in your vision, or black current or black cloud obscuring your vision. If you have any of those sorts of symptoms, it's important to see your ophthalmologist right away and have a dilated eye exam to closely look at the wallpaper, the retina in the back of the eye, to make sure there aren't any tears or detachments. And depending on the location of the detachment or tear and the how extensive it is, will determine the course of action and the treatment for that. And here we have just a little bit on the external parts of the eye. We have swelling and redness of the eyelid here on the left eye. And when you see this, it's important to find out what are the symptoms, if there's any decrease in vision, if there's pain with eye movement, if there's limitation of the eye movement. These sorts of symptoms would help you determine if this infection is only in the skin, what we'd call preseptal cellulitis, right? The infection is only in the eyelid skin, or if it's more extensive and has progressed behind the sort of barrier, the orbital septum, and reached the eye itself, the area around the eye. And here we can see the eye is very red. If we were to examine this patient, they'd most likely have limitation of eye movement, pain, vision loss, and these sorts of orbital signs would make us suspect an orbital cellulitis, which is something that would need to be treated more intensively, in a hospital setting with intravenous antibiotics, monitored closely, compared to an infection that involves only the skin layer, this could be potentially, treated with oral antibiotics and watched closely on an outpatient basis in the office to make sure it doesn't progress to something more extensive that would require, hospital admission and intravenous antibiotic medication. So yeah, we're talking about the difference between preseptal and orbital cellulitis, and that concludes the presentation on eye emergencies. And I look forward to your questions. Thank you for listening. Okay, so we've got a question here. My uncle had a tool hit his eye and had blood coming from the eye. He went to the hospital. They referred him to a specialist. Shouldn't he have gone to the specialist first? He lost some of his vision. This is a great question, and I'm so happy that you asked this question. And the thing is, when there's trauma to the eye and there's blood coming from the eye and there's a suspicion that there could be a ruptured globe or an open globe, it is important to go to the hospital because you may need surgery. And it depends on the hospital that you go to, but if it's a trauma center, a large hospital, they should have ophthalmology coverage. And if there is an open globe, ruptured globe, or any suspicion for that, they will call in an ophthalmologist to have it evaluated and potentially go to surgery, within, again, the surgery depends on all the other surgeries that are going on in the hospital. It's an emergency for ophthalmology, but there's always this sort of protocol about, if there's another patient and there's only one staff in one room, they gotta save the heart before they're gonna save the eye. It's just life before sight. So they gotta, it's not necessarily that you're gonna have surgery like that second, but pretty soon, as soon as the resources are available, the staff is available, the room is available, the operating room is ready, the surgeon is ready, within a short time, it would need to be repaired. Again, with any sort of trauma, it just depends on your local hospital and what coverage they have in terms of ophthalmology. If it's a small hospital, they may not have an ophthalmologist on site or readily available. And if you can see and if it's like during the day and, business hours, Monday through Friday, like 9 to 5, then maybe if you can get into your eye doctor, they can, evaluate you and tell you, yes, you need to go to the hospital or you need to go to the surgery center because we need to fix this in the operating room. But again, it just depends on the timing and, the resources available at the hospital that you're going to. Okay. So my eyes are very swollen, hurting, red, and very tender. Is this an eye emergency? Should I go to the hospital? So, when I hear this, I need to know a little bit more information about, the sort of time frame. If this came on suddenly, if this has been going on for a long time, if this is associated with a trauma. If there is trauma associated, I would say, and this was sort of a sudden presentation, and then you should go to a hospital, but you want to go to a hospital that has, eye coverage, an ophthalmologist available on call. If you can, if it's business hours, Monday through Friday, 9 to 5, and you can see an ophthalmologist in the office, then you should go there. Because going to a hospital, you're not going to necessarily see the eye doctor until, they get out of the office or they get out of surgery, or, it's going to be a longer sort of visit. But if you need, imaging or surgery, then it's useful. But if you can see an ophthalmologist in the office, they can triage you and tell you, yes, you need to go to the hospital and get, sort of immediate imaging or immediate surgery. Or no, you can, use this drop or treatment or something, try this at home and we'll follow you closely. So it really depends on the timing and, if there was any associated trauma. So yeah, I need to know a little bit more information, but I hope that answers your question. My eyes tear and the tears seem to have blood in them. Do I need to go to the hospital? What could this be? My eyes seem to have blood in them. That the tears seem to have blood in them. That is it's quite interesting. I think again, we want to know the sort of onset of this bloody tearing. If you have bloody tearing and you have had trauma, yes, you should have this evaluated, immediately. Again, if it's business hours and you can see an ophthalmologist right away in their office, do that. If it's after hours and you can't get to an ophthalmologist and you've had trauma and you have, bloody tears, then yes, you need to go to a hospital so that they can call the on-call ophthalmologist. My child got punched in the face and his eyelid is swollen and very painful, and he's unable to open his eye. Do we go to the hospital or call a specialist? So again, yes, you want, if you've had any sort of trauma to the face, you've had this, describing blunt trauma, a fist, to the eye, and if he's unable to open the eye, it is very important to get a good ophthalmology exam of his eye to make sure, especially, the other thing I don't know here is the age of the child. And if it's a younger child, less than 10, there's still visual development going on. So if their eyelid is closed for a prolonged period of time, that could lead to, a condition called amblyopia, deprivation amblyopia, if they're a very young child. So this definitely needs to see an ophthalmologist, as soon as possible. Now, again, if you can get to an ophthalmologist in their office, and it's Monday through Friday business hours, then that they can triage you. They're best people to triage you, right? As opposed to going to the hospital. Now, after hours, evening, you have to go to the hospital because they're not available, and you want this, you want to make sure that the structure of the eye is not compromised. There could be, as I showed you, a hyphema. If there is a hyphema, you would need treatment. You would need drops. And the emergency room, in conjunction with the ophthalmologist on call, can guide you with the treatment and the management of a hyphema. And so it's important not to delay care. I would definitely have this evaluated. If you are experiencing headaches with an aura around my eyes, what is this? Should I go to the hospital or specialist? It sounds like the same person asking these questions. It's a very similar question. So again, headaches with aura, it could be, a migraine. It could be, sometimes like an optic neuritis or some neurological conditions that are associated with the eye. So I'd need to know more information to know for sure what this is, and need an eye exam. Again, if you should see an ophthalmologist for eye conditions, and if you can't get to an ophthalmologist in their office because it's they're not open, then and it's sort of an acute process and something that's if it's something that's been going on for a long time, then it can wait till Monday, or it can wait till, the next business day. But if it's something, where you have a profound vision loss or profound, eye pain or trauma, and it can't wait till, business hours, then yes, you should go to the hospital and they'll work with the ophthalmologist on call to, evaluate you and figure out what the treatment should be. What is a Schilazin? So a Schilazin is basically when inflammatory material gets clogged into one of the glands along the eyelid. So that your eyelid has a lot of glands, and if those glands get clogged or plugged up with inflammatory material, they can harden. It becomes very painful. That's what we call a Schilazin. Why do some headaches present with an aura? So I think we talked about that one. I was in a car accident and was taken to the hospital. I had a problem with my eye and there wasn't a specialist available at the hospital. I saw the specialist a few days later and lost some of my vision. Would this have had a different outcome if I saw the specialist first? It's really hard to know because I don't know exactly what is going on with your eye. I would say that if sometimes it may not have made a difference, and that's why even though you saw the specialist a few days later, it may have been something that timing of the ophthalmology exam may not have affected the, prognosis, but it's hard to know without knowing what exactly the diagnosis was. I have redness in inner white area of one eye with no pain, no light sensitivity, no obvious vision loss. The eye was very red yesterday, but a little better today. Should I see a doctor? So this is something that, we get this question a lot, like even from friends or family, or, sometimes people can get what we call a subconjunctival hemorrhage. And the funny thing is I had a picture of that in my presentation. I decided to take it out because it's not eye emergency, right? So, but it's something that, can scare you if your eye is, red on one side. Basically, there's, like is described here, some redness. There's no swelling, just redness on a part of the eye that's, the white part. There's a clear covering there called the conjunctiva. And sometimes the tiny blood vessels that are in that clear covering, the conjunctiva, they can, rupture. It could be if you rub your eyes a lot, or if there's, sometimes it just happens, idiopathically, or, if the eyes are dry, it can happen. It just, sometimes it happens and we don't even know what the cause is. But those tiny blood vessels in the conjunctiva, they rupture and they cause a little hemorrhage, and we call it a subconjunctival hemorrhage. Most of the time, it's nothing to be worried about. You can use artificial tears. You'll just wait, and it'll clear on its own. Rarely it could be associated with something else. But, if it doesn't go away on its own, then yes, it should be evaluated. If it's associated with any sort of pain or vision loss, then yes, it needs to be evaluated. But, if it's there in isolation and it goes away, then, it's simply a subconjunctival hemorrhage and nothing to be worried about. I have migraines with a red ring around the eye. A red ring around the eye. This is something new. No inquiries. Do I see an eye specialist? So I'm assuming the red ring around the eye is the actual, like an external photo, like you're seeing, redness around the eye itself, not, what you're visually seeing, because not a visual aura. But I would say it's a good idea to see your eye doctor to get it evaluated. Is it necessarily an emergency where you need to go to the hospital today? I think you can schedule an appointment, with your ophthalmologist and just have your eye checked out, have the pressure checked, have, your vision checked, the back of the eye, the front of the eye. They'll look for any signs of inflammation. They'll look for any signs of infection, any signs of glaucoma, and, they'll tell you, what the next best steps are. But, there's no harm in getting an eye exam. And quite frankly, I think that everyone should get an eye exam. Depending on what eye conditions you have, you may need an eye exam more frequently than others. But at least, if you don't have any conditions that are concerning, at least every 2 years, it's good to get an eye exam. If not sooner, if you have high-risk conditions, like diabetes or high blood pressure, or, any sort of eye diagnosis like wet macular degeneration or glaucoma, obviously you're seeing your eye care provider much more frequently. I hope that answered all your questions.
I want to thank Dr. Malley, for your excellent presentation. Thank you all and have a good day.